Well, one of the things we're missing is an understanding of, and this is true of all cancers, is the crystal ball to tell people who's going to respond and who's not going to respond well. And that's obviously what all physicians want to know. And the idea is, if you had ways of assessing that, could you up front tell people who are at higher risk of disease and who you expect to do better? That could drive management decisions as far as what type of TKIs to use. It also kind of creates an expectation that you can, with you and your patient. So what we did was we looked at patients in the ENESTnd trial, which was a trial of CML chronic phase patients newly diagnosed, randomized between two different doses of nilotinib or imatinib. And we took their diagnostic samples and we kind of divided these into two groups. One who had a great response, who got a major molecular response or even a deeper molecular response to 4.5 log reduction, versus those people who had really a poor response, who didn't respond to therapy in the first 3 to 6 months or had a very poor response and never achieved an MMR. And we did RNA sequencing on these to see if there's differences in genes that are expressed in those two groups, and whether there are differences in pathways that you can infer from those gene differences. And indeed, we found that there was a very strong signal, and the quality of the signal and the quantity of the signal was kind of surprising, because it looks like if you looked at most of the genes that were differentially expressed, they were genes actually that were involved in immune response. And if you look at the pathways, the top 20 pathways that were overexpressed in great responders were all involved with immune regulation. And you can infer from the gene expression the types of cells there, and it looks like the most activity were in cytotoxic T cells and NK cells. And this seems somewhat paradoxical that you could have the disease, if the immune response is so revved up in the good responders. One, why did they get CML in the first place? Why couldn't it be held in check? And two, this kind of seems paradoxical that the immune response would be up at diagnosis in the group that ended up getting the best response. And so what we think is going on is that somehow the poor responders aren't generating any type of immune response. So that makes sense. The good responders do, but they're somehow protected. And it looks like they're PD-L1 and PD are high in this group. So that sort of protects them from the immune response. And it's almost like a predator-prey experience, where it's like when the wildebeests all mate and have babies at the same time to overwhelm the lions, right? And so here you've got a situation where the proliferative excess of the CML just overwhelms the immune response to it. And then when you give tyrosine kinases, you kill off the differentiated committed cells, thus leaving a residue of early progenitors and stem cells that now this revved up immune system can wipe out. And that may well explain the type of multi-kinetic effects we see after TKI therapy, where you get a rapid decrease in the BCR-ABL signal, and there's a slow petering out as it goes down to zero. So maybe what's going on early is you wiping out the sensitive clones. The resistant clones now are exposed to this activated immune system, and they mop out the rest of the disease. So there's got to be a lot of work left to identify what cells are producing what factors. But theoretically, this is a way that we could potentially pick good and bad responders and think about ways to mediate the immune system to get people into a deeper molecular response.